One. Please start. We are live.
Hello, good evening to everyone. I am Akhil Momin from marketing team Procare-CV division Macleods. To all, cordially invite you all for this cardio masterclass to all DM DNB students for attending and the key examination oriented presentations with the Viva and followed by the case presentation. So now I would like to hand over to Dr. Chami Prajapati to introduce our eminent speakers, panelists, and head of departments. Over to you, Dr. Chami.
Thank you, Mr. Akhil. Very good evening, one and all. Very good evening, senior doctors and fellow doctors. We welcome you all to this Cardio PG Masterclass program. So in the past, we already have had 6 successful sessions. And the objective here is to facilitate learning and support a young cardiology resident in their upcoming Vivas. So to brief all the delegates, we have Professor Dr. Ajay Mahajan sir and Professor Dr. Kamal Sharma sir as our course director of this program. And the topic of the case presentation today by PG student would be on the topic hypertrophic obstructive cardiomyopathy. And the keynote presentation that would first be taken would be on HOCM, CAT finding, and LVOTO by our esteemed speaker, Professor Dr. Mohit Gupta sir. And these are our senior faculty members who are part of this program. And I now have the opportunity and honor of welcoming and introducing our course directors and senior faculty members. We have Professor Dr. Ajay Mahajan sir, who is Senior Consultant Interventional Cardiologist and HOD of KEM Mumbai. We have Dr. Kamal Sharma sir, who is Senior Interventional Cardiologist practicing at the Sal Hospital and UN Mehta Institute of Cardiology, Ahmedabad. And for today, we have Dr. Rabin Chakrabarti sir as our esteemed senior faculty member. Sir is Senior Consultant Interventional Cardiologist and Electrophysiologist, Senior Vice Chairman of Cardiology Services at Medica Group of Hospitals. And we have Dr. Mohit Gupta sir. Sir is Senior Consultant Interventional Cardiologist at JP Pant Hospital, New Delhi. And we have Dr. Shaswat, who is the 3rd year DM PG student, cardio PG student, and we wish him all the very best. And with this, I hand over to Dr. Kamal Sharma sir. Thank you all.
Hi, good evening, everyone. First of all, let me welcome all of you for this penultimate session. After this, we have one more session left for the PG training and a very successful course that's been attended by more than 500 plus live audiences and more than 1,000 faculties. And it's an honor for me to have my friend, Professor Mohit Gupta. It's been turning the favors back. Actually, I've been invited by him so many times in Cardio Delhi CSI programs, and I think I'm not even returning even one lecture to you. So my apologies, and with due respect, one of my good friend, Professor Mohit Gupta from GB Pant, is going to talk about hemodynamics in hypertrophic cardiomyopathy, which is the case. And it's an honor to have Dr. Professor Rabin Chakrabarti, who's such a senior faculty. He was there with the last session, and he's going to take us through the Viva Voca on HOCM today. And I think we'll have him again for the EP tracings the next week as well, sir. So looking forward to the session, and I hand it over to Professor Mohit Gupta, who will take this for a change before the case presentation because he has a social emergency which he needs to attend in the later part of the day. Over to Dr. Mohit.
Thank you, Kamal. Thank you so much, Team Macleods. Thank you, Professor Rabin Chakrabarti, and all my dear friends. Thank you for this terrific opportunity. I'm going to unravel the hemodynamics in hypertrophic cardiomyopathy. I'm going to show you 5 things that is going to completely clean and give you a clear perspective and deeper insights into what kind of questions you are going to be asked, what are the mechanisms that are operating, and how and what is the stepwise approach to diagnose this. We all know that hypertrophic cardiomyopathy is actually characterized by increased LV wall thickness that is actually not solely explained by the abnormal loading conditions. So what is the pathophysiology? 4 things are happening. We know we have a diastolic dysfunction, which can extend from moderate to severe. We have a significant LVOT obstruction, left ventricular outflow tract obstruction. We have mitral regurgitation due to various mechanisms. It could be due to, SAM, it could be due to abnormal chordae, it could be due to abnormal valve, and we have impaired coronary flow reserve. So let us take each one of them one by one. Diastolic dysfunction is almost present in all patients due to impaired relaxation. We have decreased passive early diastolic filling and exaggerated atrial systolic filling, which is responsible for S4 and rapid clinical deterioration on development of AF. So what happens? Because of this, the patients have an increased left ventricular end diastolic pressure. Also, these patients have an increased left atrial pressure, especially in presence of MR, and consequently, when we see their hemodynamic traces, expectedly, we are going to see a prominent A wave and a prominent V wave, probably from a mitral regurgitation. Look at this. This is what is happening. So simple trace of a hypertrophic cardiomyopathy would start with the elevated early diastolic pressure and a prominent A wave. This is what is happening when these patients have a prominent diastolic dysfunction. When these patients have a left ventricular outflow tract obstruction, this could be caused by a SAM. It could be caused by a thickening of the left ventricle, dynamic in nature. Changes depend in the filling pressures like afterload and the force of contractility. And in contrast to valvular AS, which has fixed obstruction, this is completely dynamic. How do we classify? Basal obstruction at rest is when we say that outflow gradient is more than 30 millimeter, equal to 30 millimeters of mercury. Non-obstructive when it is less than 30. And when it is physiologically provoked, again less than 30, it is non-obstructive. On the contrary, labile is when physiological provocation is increasing more than or equal to 30. Remember, any gradient more than equal to 50 is considered to be a threshold for a septal reduction therapy in these severely symptomatic patients. So how the pathophysiology is working? Look at this. As in valvular AS, we have a uniform obstruction. So we have a delayed upstroke in the aortic pressure. Look at the delayed upstroke. We have a large systolic gradient beginning in the early systole and peaking at the maximum left ventricular pressure. This is what is happening in the aortic stenotic patients. On the contrary, look at this. Look at this very important trace, the first hemodynamic trace of hypertrophic cardiomyopathy. There is no obstruction at the onset of ventricular ejection. So what will happen? The moment pulse is the LV shoots the blood, we have a brisk initial upstroke culminating in a peak systolic pressure. Look at this. As my arrow goes up, we have a peak systolic pressure. As the obstruction progressively develops during systole, as the contractile force of LV builds, when it reaches the maximum, the aortic pressure drops. Look at this. There is a drop in the aortic pressure. And then again, there is a delayed upstroke, the secondary injection, and then the waveform comes down and down like a typical aortic pressure waveform as compared to the valvular stenosis. So this is what gives rise to a bifid pulse in a hypertrophic cardiomyopathy, both in the systole as compared to the other cases where you have one in the systole and one in the diastole. That is why it is called the spike and dome pattern. Spike and dome pattern. So pullback traces in an SCM. Now look, I'm going to make you understand that how do you interpret these traces. Look at this. Very simple trace. Whenever you are given this trace, why don't jump into this? Look at this. We have two traces. One is the aortic pressure. How do you identify the aortic pressure? The diastolic pressure is higher. Look at this. The diastolic pressure is higher. And we have a bifid pulse. So this is the aortic pressure that is running. On the contrary, this is a pullback trace from the left ventricle, and we have the diastolic pressure, which is typical of the left ventricle, and a large or a high systolic pressure. As you are pulling back, look at this. There is a sudden drop in the pressure at the level of the ventricle, and that is what causes the obstruction below the valve. Why below the valve? Because the diastolic pressure is still low. That is why we interpret that this is hypertrophic cardiomyopathy and not a valvular obstruction, because there is a gradient in the left ventricular cavity, and this is very, very evident because the diastolic pressure is still typical of the left ventricle. And as you pull down and up and up and up, look at this, there is no gradient, and the catheter suddenly comes out into the aorta, and the diastolic pressure is same as that of the aorta. That is why you interpret that this is a classical obstruction of the hypertrophic cardiomyopathy. To make you understand more easily, this is a valvular AS. Now look at this. When the obstruction is only at the valve, a pullback trace from the ventricle pulling, you pull the catheter, and suddenly you see across the valve, the diastolic pressure comes typical of the aorta, and the gradient is right at the valve, and hence we interpret that this is a case of a typical valvular aortic stenosis. Talking about the supravalvular AS, look at this. Again, now we interpret two things we have to see: the change of the pressure and the diastolic pressure. A pullback trace of the left ventricle, diastolic of the ventricle, and we have a high pressure, which is showing a high systolic pressure in the ventricle. You pull, and again pull, and suddenly as you jump across the valve, the diastolic pressure is typical of the aorta, but still there is a high systolic pressure that shows that the obstruction is above the valve. You pull the catheter further, the diastolic pressure remains the same, and there is a gradient across that obstruction above the valve, and this is what is diagnostic and classical of the supravalvular AS. That is why if you want to differentiate whether it is below the valve, at the valve, and above the valve, we need to focus on both systolic and diastolic pressure and where are the changes occurring. This is the key. Don't rattle this, don't mug this up. Try to interpret, and you will never falter in interpreting these hemodynamic traces, my dear friends. So this is in brief about the interpretation of the left ventricular gradient. Dynamic nature of LVOT gradient, significant variations are observed at rest. There are beat to beat fluctuations which can be seen without the changes in the catheter interpretation. A word about the inspiration, which causes decrease in the gradient. Why? Because with inspiration, the intrathoracic and the intrapericardial pressure decrease, and they decrease to a greater extent than the intracardiac pressure. What will happen then? Because of this, the left ventricular transmural pressure will increase and the afterload will increase. The moment afterload increase, the obstruction will decrease, and hence the left ventricular outflow gradient will decrease. Look at this. In inspiration, there is a decrease in the left ventricular outflow tract gradient as compared to the expiration, where the transmural pressure decreases, afterload decreases, and hence the obstruction increases in expiration. The third thing that I want to tell you, classical Rockenborough, Braunwald-Morrow sign. Often I have seen that people, residents will try to mug this up. I'll make you understand why this is occurring and why it is not occurring in other conditions. If you're asked to define, it's paradoxical decrease in pulse pressure during the post-extrasystolic beat seen in patients with hypertrophic cardiomyopathy. And now why it is occurring, I'm going to tell you. Normally how it happens. Normally, without dynamic obstruction, when a PVC is given, what will PVC do? PVC will put the heart into a refractory state, a longer filling period, a compensatory pause. When there is a compensatory pause, what will happen? The left ventricular and diastolic volume will increase. When the left ventricular and diastolic volume will increase, there is post-extrasystolic potentiation, the stroke volume will increase, the arterial pulse pressure will increase, and there is an increased cardiac muscle stretch leading to increased myocardial contractility. So when a typical PVC is occurring in a normal heart, you have an increase in the pulse pressure, increase in the contractility, and this increase is normally not seen in the dynamic obstruction. Now, what happens in a case of a hypertrophic cardiomyopathy? Look at this. The moment there is a PVC which occurs in a case of a HCM, what will happen? The blood pressure, the volume of the left ventricle is going to increase, but the left ventricle contractility significantly increases. The moment left ventricle contracts after a post PVC, what will happen? It will obstruct the ventricular cavity, and hence the left ventricular pressure will increase, but because of the obstruction, the arterial pressure decreases, and hence the pulse pressure decreases. So when the pulse pressure decreases in post PVC, in dynamic obstruction cases, this is called a Brockenborough-Braunwald phenomena. Look at this. The moment PVC comes, you have a very powerful myocardial contractility. This myocardial contractility will increase the left ventricular pressure. This is not able to translate into an increased arterial output or arterial pulse because of the obstruction, and hence the pulse pressure will decrease. And this is why we have a Broken-Brown-Wald phenomena in case of a hypertrophic obstructive cardiomyopathy. Look at this again. This is a very classical trace shown to most of you in the exam, and you should never mug it up. You should know why this is happening in a normal heart and why this is not happening in a typical hypertrophic case. Post-septal myectomy, it will not occur. Why? Again, because there is no dynamic obstruction. A typical case of AS, this will not change after PVC. A typical case of post-AVR, again, you see, this will not change after an aortic valve replacement. So this is a very pathognomic sign of a hypertrophic obstructive cardiomyopathy. So now, coming to different methods of typical left ventricular OT gradient. These are very classical book descriptions. You can read it from the book. I don't have time, so I'm not going to take it. But I'm going to show you the fourth thing, which is the LV angiogram. LV angiogram in these cases are often shown to you as a spotter. And what is the hemodynamics behind it? These patients have a marked LV hypertrophy. They have prominent papillary muscles. They have asymmetrical hypertrophy of the interventricular septum. They have a hyperkinetic LV with a typical cavity obstruction, which is a banana-shaped LV. They have an increased calculated EF. Because of a hypercontractility, often you see the mitral regurgitation, which is manifesting, and this often gives a spade-like manifestation of a LV. Now, I'm going to show you all of these things in an angio. Look at this, the angiogram that we did in our patient. Look at this. This is a very, very classical case of a hypertrophic obstructive cardiomyopathy and an LV angiogram. Look at this. The moment it is, look at this. This is the LV cavity. Look at the severe obstruction the patient is having. Because of the PVC and also this obstruction or this severe obstruction, look at the mitral regurgitation, the filling opacification of the LA. Look at this. And also you also see the amount of the muscle hypertrophy that is seen here. This is a very classical case, a very classical picture of a LV angiogram of a case of a hypertrophic obstructive cardiomyopathy. Look at this, the definition of the mitral valve. How beautifully in this particular case we are able to demonstrate and see everything in a typical LV angiogram of a hypertrophic cardiomyopathy. If you are asked what about the RV gradients in HCM, yes, it is rarely seen in adults, but it is very common in infants and children. Maron has described that RV obstruction is seen in 60% of the infants. Though I'm not seen, typically I'm not seeing those cases. I'm not seen an angiogram, but for these practical purposes, you should know that RV outflow tract obstruction is frequently seen in infants and also in children with hypertrophic obstructive cardiomyopathy. The last thing is coronaries in HCM. Now, what is happening to coronaries? Coronaries have a higher resting blood flow, lower resistance, lower coronary blood flow, and a systolic compression known as myocardial bridging. This gives rise to typical three findings that we all should know. Typical myocardial bridging, we have published a case of myocardial bridging in JACC in all three coronary arteries. You must see that particular angiogram where we are seeing a bridging in LAD, we are seeing a bridging in left circumflex artery and also in the RPDA. Such can be the severe obstruction that you can observe bridging in all the three cases. Now, when we typically image the cases of a hypertrophic cardiomyopathy with OCT and IVOS, we get two classical signs which are shown to you in exams and you should be aware. Go and read about them in detail. One is the fusiform area that can be observed during diastole in an optical coherence tomography. Look at this star. A typical fusiform area. Look at this. This fusiform area, this is very, very classical of an image of OCT in a hypertrophic cardiomyopathy. On the contrary, in IVOS, we see what is known as a half moon sign. Look at this. A typical IVOS image would show a half moon sign, which is distinct from the heterogeneous fusiform area. So these are the two classical signs that have been described in a case of a hypertrophic cardiomyopathy. Lastly, I would like to talk a bit about a couple of slides about hemodynamics during percutaneous alcohol septal ablation. We all know that the classical indications for alcohol septal ablation is class 3 and 4, LVOT gradient greater than equal to 50, septal thickness more than 18, and obviously the compatible septal branches and absence of coronary artery disease. Now look at this. A very classical case of the significant obstruction across in the left ventricle. Look at this. How significant is the gradient? And this is the target septal artery. What we do is we are doing a balloon inflation of the septal artery, and this is what happens. The gradient significantly decreases, which is indicative that yes, we might be successful in ablating this gradient. After the alcohol ablation, this is what you observe. Look at this, septal is gone, and we get a very classical disappearance on significance lessening of the gradient across the left ventricular cavity. So these are the 5 important hemodynamic features that we all should remember about the hypertrophic cardiomyopathy. One is what we are having is an increase in LVEDP, the classical increase in A wave. We also have a very classical finding of the Broken-Brown valve phenomena in the hemodynamic monitoring. We also have a very classical sign of a bifid pulse or a spike and dome pattern. I explained you the mechanism. I also explained you the mechanism of why Broken-Brown valve phenomena is occurring. And then we have the classical LV cavity, this LV angiogram, which is a banana shape. We have a mitral regurgitation, and then we also have typical findings of what I told you was post alcohol ablation, and then we have the typical findings of the this typical Broken-Brown valve phenomena. So these are the 5 things that are commonly asked about the hemodynamics of the hypertrophic cardiomyopathy. So this is all from my side. I hope I'm able to make you understand the pullback traces also, how to interpret them, and this will be of some utility to you in your examination. Thank you for your patient hearing.
Thank you, Dr. Mohit. That was wonderful as expected. 5 new things, and I was looking, there would not be any repetition, and I'm glad that none was a repetition. A lot of lectures we have heard on HOCM from a lot of other experts. Usually those are the repetitions of the things, but those things are usually covered in the Viva Voca with faculty like Dr. Robin and yourself. I'm sure those questions will pop up, what are commonalities to be asked, but what you have covered are something explicit and exquisitive things that are different from what normally we read. So thank you very much. And now I will invite Dr. Shashwat to present his case on hypertrophic cardiomyopathy. Dr. Mohit, I would request you to grill in the initial part, and whenever you have to leave, you can just leave. That would be fine. We understand with your social. So we'll have Dr. Mohit do the honors of the Viva Voca to start with, and then probably Dr. Rabin and I myself can also join in. Yeah. Dr. Shashwat, you can start with slideshare.
Yes, good evening, sir. Sir, am I audible?
Yes, you are audible.
So is my presentation visible?
Yeah, it is visible. Just go ahead.
Okay, sir. So shall I? Okay, sir. Good evening, everyone. I would like to start my clinical case presentation. I am a third-year resident from SCB Medical College, Cuttack. So, sir, a 27-year-old Hindu male, a laborer by occupation belonging to the low socioeconomic group, presented to the OPD with the chief complaints of exertional shortness of breath since last 4 months and exertional chest pain since last 3 months. The patient was apparently all right 4 months back when he noticed shortness of breath on exertion, which was insidious in onset. The shortness of breath was NYHA class 2 as the patient became breathless on doing regular activities like walking 1 to 1.5 to 2 kilometers, climbing 2 flights of stairs while loading and unloading bricks onto his vehicle, and the breathlessness was relieved by rest, and all these activities he could do easily in the past. The patient also developed chest pain on exertion since 3 months. The chest pain was NYHA class 2. It was retrosternal, heaviness and tightness in the chest, radiating to both the shoulders and sometimes to the back, and lasted for a few minutes on exertion and was relieved by taking rest. There was no history of orthopnea or PND, no history of cough with expectoration, no history of cyanosis, no history of syncope, presyncope, giddiness, or loss of consciousness. The patient has no significant history in the past, non-hypertensive, non-diabetic. The patient had an elder brother who had a sudden cardiac death at the age of 30 years.
Smoker or non-smoker? Smoking?
Sir, chronic and occasional smoker.
Okay.
Yes, sir.
Yeah, go ahead.
Yes. While on work 2 years back. Then, sir, summarizing my case, a 27-year-old male patient with history of shortness of breath, NYHA class 2 since 4 months, and angina chest pain, NYHA class 2 since 3 months. No history of orthopnea, PND, or syncope, and history of sudden cardiac death of elder brother at the age of 30 years. 2 years back. So, sir, on the basis of history, I have made a provisional diagnosis of LVOT obstruction in the form of hypertrophic obstructive cardiomyopathy, coronary artery disease like in familial hypercholesterolemia, and sir, rarely bicuspid aortic valve with aortic stenosis, which is severe.
I think what I suggest,
Let's-
firstly, in the pain you mentioned anginal pain. So
Yes,
I
sir.
suggest that do not mention that angina word. It should be
Okay,
something
sir.
exertional chest pain, because that is the appropriate way of presentation. Because the moment you say angina, we attribute it towards the coronary, ischemic coronary artery disease related ischemia. May not be obstructive disease, but it's something to do with the coronary artery circulation.
Okay, sir.
So I
Can we
would
go to the
prefer
first
not to
slide?
use the term angina.
Go to the
Yes.
first slide. First slide, yeah, go. Okay, now, 2 or 3
Yes.
very basic things that I would like to tell you is that, you
Yes.
know, it's great when you're talking about the occupation. Definitely, it looks like a hard worker. When you're talking
Yes.
about the socioeconomic status, you should be very clear about which classification you are using. Kupuswamy with scale, because some examiners may be fond of it, they will hold you. The second
Yes.
thing that I would like to tell you is exertional shortness of breath since last 4 months or since 3 months. Okay, so these terminologies you have to be clear. It cannot be since, it was for last 4 months, and exertional chest pain for last 4 months. So the moment you say, as sir very rightly said, the moment you are mentioning angina, my first question would be, how do you define angina? What are the 3 important prerequisites of angina, isn't it? If you say it's a
Yes, sir.
classical angina, yes, just name 1, 2, 3. You should be aware of that.
So first is the typical Hayward's classification, that is heaviness, choking sensation, tightness in the chest, radiating to the arm or the back or sometimes to the neck, which increases on exertion or emotional stress or while cold, and which reduces on taking rest or while taking nitroglycerin.
So did this pain relieved on nitroglycerin?
Sir, actually, he says that the pain reduced on taking rest for a few minutes.
So do you think this for classical angina, how many features should be fulfilled? All 3, right?
All 3.
All 3.
Sir.
If it is less than that, it is called as a
Atypical chest pain.
atypical angina. So definitely, as sir very rightly said, it's always good to mention a classical exertional chest pain, though these HOCM patients have a angina chest pain also. So why these patients have angina and why these patients have a typical case of a breathlessness? What do you think a 27-year-old male, he has a, why do you say it's a significant family history? I say it is non-significant. Had this patient had a brother who has been, or a father who had been dead at around about 60 years of age, would you call it significant family history or not? When do you call it
No,
as a
sir,
significant family history? Yeah.
So family history in first degree relatives less than 50 years of age and contributable by a likely or a
Very good.
defined hypertrophic cardiomyopathy.
Perfect. So very good. So this is very important that was the cause elucidated in the family or not?
No, sir.
There was
This
history?
was
No.
not.
After the sudden death of this, did any doctor recommend a screening of the whole family? Are you aware
No,
of this or not? You
No,
should
sir.
be taking this history. You should be taking this history, because if sudden deaths are occurring and they're showing to any relevant physician, many of the good doctors and showing to a good cardiologist, they would recommend a screening of the whole family. So this kind of a history you should be including in this negative. So what you're doing is you're consolidating your knowledge and also strengthening your point, isn't it? Now, as you rightly said, this patient, a 27-year-old young male with shortness of breath and chest pain, could either be a valvular, could either be a coronary, or could be a structural disease, isn't it? That is how. Now you have a smoker male. You have a smoker male with a strong family history, which could be of, which is a sudden cardiac death. It could be coronary, or it could be a structural also, LMIC also. What would be your first differential, as you rightly said? It could be a cardiomyopathy, isn't it? Did this patient at any particular time have orthopnea and dyspnea? Orthopnea?
No, sir. He had dyspnea, but not orthopnea.
No orthopnea. The progression has been over how many years now? Only 3 months and 4 months? There's been no other history? Go to the next slide.
Yes, sir.
Go to the next slide. Are there any relevant manners? Yeah, go back. Are there any other aggravating factors or relieving factors besides this? Go back to the chest pain and the dyspnea. Any other? Stay here. Any other relieving and aggravating factors besides this?
No, sir, not besides this.
No. So a patient of 27 years old has been presenting within 3 months with class 2. Has it been progressive or not over 3 or 4 months, or it has remained only class 2?
So only class 2.
Only class 2. So only class
Yes.
2, once you're having, definitely you have to keep a possibility of both coronary artery disease and also first as a hypertrophic cardiomyopathy, as you have rightly said. Any other questions, sir, from your side?
Yes.
No, I think this is the only thing that the second part, when you say that the shortness of breath, NOH class 2, as the patient becomes breathlessness on doing regular activities. No, there are no, if you really want to build your case, because in the history only you have to build your case. There are 2-3 points are important. Like, having kind of a shortness of breath on walking or even pain on walking. That is one. Probably it would be appropriate to have kind of a shortness of breath while climbing stairs to start with, or unloading, loading to start with, and then the walking part comes in. Right. So that is a better way of, because that's how the story is being built. So this is just a suggestion. Now, as Dr. Mohit said very rightly, that when you've got a history of sudden cardiac death of his father, it is important to find out whether what was the cause, or any family member has been asked to screen, or any other member for that matter of the family had any echocardiographic diagnosis of hypertrophied heart. What could be whatever may be the reason, because that is a very strong pointer. Then you can link these together to support to defend your diagnosis while presenting the history. These are the very two important points.
What are the causes of dyspnea in these cases? Why do we have dyspnea in these cases?
Dyspnea is attributable to either because of diastolic dysfunction, sir, and
So,
secondly,
one.
development of
So
any
what?
arrhythmia like atrial fibrillation.
Arrhythmia is very
happens?
unlikely, very. Hypertrophic
So-
cardiomyopathy going into arrhythmia is probably the last thing to happen.
So there are
Why
four
shortness
things.
of breath?
There are 4 things that are happening in this. What are those 4 classical features that manifest as dyspnea in a patient of a hypertrophic cardiomyopathy? They have diastolic dysfunction. Sir said, so what? So what will happen once diastolic dysfunction is happening? So what happens consequent to that? As I just showed in the presentation, it leads to increased
what? Increase
LA pressures and increased blood
increase
pressure.
filling pressures, increase
Affected
LA
veins.
pressures. It will lead to increased
Filling pressures.
myocardial oxygen demand. These patients have a
Myocardial
impaired,
oxygen.
microvascular dysfunction. They might have
Coronary
resulted
reserves.
to very good. They have a coincidental CAD and poor coronary reserve, and they might have mitral regurgitation. So these are the causes that these patients have a impaired or a dyspnea. Why do these patients have a myocardial ischemia or angina typical?
Sir, because there is mismatch between the myocardial oxygen requirement as well as the demand. The
Very
requirement
good.
increases and the demand reduces. Second,
Very
sir,
good.
due to LV obstruction, there is incomplete emptying of the LV because of the obstruction, and there is increase in the LV and diastolic pressure, which again causes reduction in the coronary filling. Sir.
What else?
And sir,
no, the other point,
25%
somebody is having hypertrophic cardiomyopathy, and he's doing exertion. Let's say climbing stairs or walking fast or loading, unloading. What happens to the heart rate?
So it increases. So there is tachycardia.
What happens to the breathing? And a normal person.
Again, sir,
what happens to the breathing? A normal person, if you unload, what happens to anybody who is normal? What happens to the breathing? It decreases or increases?
Increases, sir.
Fast. So relatively fast. What happens during fast breathing?
Yes, sir.
And during sort of fast heart rate to this dynamicity obstruction, which Dr. Mohit sort of depicted so nicely? What happens to that? Because that is related to the ventricular emptying. What happens to that? Left ventricle has to empty, empty, and blood has to go to the circulation. Now there's an obstruction, which is dynamic. So what happens to that obstruction during tachycardia and during tachypnea? This is hemodynamics. You have to just you make some statement, guess. The moment you guess, then we can talk about it. No. I think Dr. Mohit, you need to again probably come back to your presentation, your kind of hemodynamic theory.
So my next question to you is, are we seeing your slides? Can you project them? Yeah.
I think he probably lost the connection. Tech team, can you connect? Akhil, can you connect back to him? I think he just got disconnected. Yeah, he's here. Sure. Yeah, Dr. Shashwat.
Come back to your slide.
Yeah, Dr. Shashwat, we lost your presentation.
No worries.
You're mute. Unmute and share your slides.
Sir, just a second.
What is another classical feature of the angina that occurs in patients of hypertrophic cardiomyopathy?
Cardiomyopathy. Different angina.
Sir, in these cases, sir,
What is the classical?
mostly associated with postprandial angina, sir.
Very good. Why it is postprandial?
Why?
Beautiful.
Sir,
Why it is postprandial?
after half to 1 hour after taking food, there is a mesenteric vasodilatation, sir, and there is
Very
increase
good.
in
It's mesenteric
mesenteric blood supply, so that there is a decrease in the afterload, and the apparent obstruction increases. And on top of that, there is some amount of
Hello?
coronary steal phenomena, sir.
You muted yourself. Are you able to hear me?
Yes, sir. You are audible, sir.
Shashwat?
Sir, you are audible, sir. Hello.
Yeah, I think we are all audible.
Yeah, we all can
I'm
hear
not
you,
able to
Dr.
hear you.
Mohit. I
Hello?
think, can you hear us?
Yeah, now you can go ahead. Okay, now.
Hello.
Okay, start.
Dr. Mohit,
Am I
can you
audible?
hear us?
The simple thing is that during afterload, sorry, there's more afterload, there's more obstruction, right?
Yes, sir.
So now to summarize your case, there are three possibilities only. Now let me tell you, if I want to say, come on to the differential diagnosis, Yeah, now look at
Sir.
it. Now, what are the points in favor? What makes you think that it is LVOT obstruction and not coronary artery disease first? What makes you think that bicuspid aortic valve with aortic stenosis could be only the third one?
I would rather prefer not to mention this anatomy. Bicuspid is the anatomy. Don't mention in the history.
You can say a valvular aortic stenosis,
something like that.
or something obstruction at the valvular particular level. Okay. Now tell me that why do you think that this is LVOT obstruction first? Why not coronary artery disease and why not bicuspid aortic valve? Now go ahead. Come on.
Sir, LVOT obstruction because sir, there is
Points in
positive
favor,
strong
points
family
against.
So points in favor is, sir, HOCM can present at any age. So it could be the age of presentation. Second, sir, there is a positive, strong family history of sudden cardiac death in a relative which is less than 30 years of age, sir.
Sudden cardiac death, a short
Yes,
history relatively, 3
Yes,
months
sir, short history.
rapid progression, and you say the progression which is there, classical symptoms of dyspnea, and patient having an angina.
Angina.
Why coronary artery disease is a second differential diagnosis and not the first one? What are the points in favor of coronary
So
artery disease?
because the age of the patient is 27 years of age. So sir, CAD in 27 years of age patient is quite rare, sir, unless it has some familial inheritance, sir.
Okay,
In
that's
those
fine.
cases, smoker is in points in favor and tobacco chewer. But again, I think
Yes,
that
sir.
is relatively, this is definitely not the topmost priority. The coronary is number 2. Yeah, that I also agree.
Why not? I would have kept a rheumatic valve or a bicuspid aortic valve basically, or a affliction at the aortic valve above. Why did you keep it at the third one? And what are the points in favor that point towards a patient having a severe aortic stenosis? Suddenly 3 months rapid progression. Is it observed so fast and rapid in these patients? Possible
No, sir,
or not?
it is not. It is not so common, sir.
What happens in these patients?
Sir,
What is the
usually they
classical
present
natural
late,
history
sir.
of a bicuspid aortic valve.
Sir, bicuspid aortic valve are relatively asymptomatic for longer duration of time. As age sets in, sir, there is a calcification. But as the aortic valve is already bicuspid, with superadded calcification, they present earlier than the other cases like rheumatic aortic stenosis or degenerative aortic stenosis.
Yeah, I think what I suggest, sort of, don't categorically mention calcification right now. What you can say that time with age, there is progressive degeneration.
Degeneration,
right?
yes.
That is a better word because calcification, there could be calcification even, there may not be any sort of, the degree of calcification, there is no correlation that with the degree of calcification, the severity also increases. There is no such correlation. But yes, we see in severe aortic stenosis more calcified aortic valve, even in bicuspid aortic disease. But if scientifically, if you make a statement, you say that it is a progressive degeneration. Degeneration is progressing. Now, commonest cause of degeneration in this case, of course, calcification.
Yes.
Can these patients have paroxysmal nocturnal dyspnea hypertrophic cardiomyopathy?
Sir, HOCM patients.
Why do they have less PND otherwise typically?
Yes, sir. The PND is very uncommon with hypertrophic obstructive cardiomyopathy because, sir, one of the mechanisms, sir, it is given is during night, sir, there is a reduction in the heart rate. So as heart rate
Right.
reduces, the diastole is prolonged. So as diastole prolongs, sir, there is more filling of the LV, which causes LV cavity to increase. So the obstruction reduces, sir.
Very good.
What about the
Beautiful answer.
sympathetic
All
tone
of
in
you
sleep?
should note this.
And
This is a very
sympathetic.
appropriate answer that Shashwat has given. And many of us falter in this. Very nicely, he has explained. We must appreciate that PND is less common in patients of hypertrophic cardiomyopathy because of the slow heart rate, which improves the diastolic filling. And this actually diastolic heart failure improves in cases of hypertrophic cardiomyopathy. And hence, we have less PND, which is occurring in these patients. Very, very good. So this is what is the mechanism of less reason why we have less PND in these particular cases. Okay. So should we go on to further and any other thing that we want to
Any other
take care?
anything else? Family history mentioned. Any other points? Go to the next before just previous slide.
It is very appropriate, Shashwat, once you are taking that, you should also draw and take a complete family tree, isn't it? It is expected.
Yes, sir.
Once you are dealing. It is very important. Logically, siblings and complete, we would have been very happy if you would have shown a chart here only, that this is the complete family history. That would give you extra marks. I'm not cutting your marks for this, but it shows that you are going extra mile the way you are answering, that I have a complete family history. Because if we have a couple of cases more or typical this will improve the value of our case. May I ask you that presence of a family history in the newer classification is a major or a minor risk factor for hypertrophic?
So it is a major risk factor.
Very important risk factor.
Nice.
It is a very important. It is given significant points on this. How do we define a typical family history? As you said again, can you repeat it? A positive family history is what?
Yes, sir. History of sudden cardiac death in first degree family member less than 50 years of age, which is definitely due to hypertrophic cardiomyopathy or likely to be due to the hypertrophic cardiomyopathy.
Go ahead. Now go ahead to the examination.
So
So
on
how
general
is
examination, the patient is
Shashwat?
Kamal sir,
Or-
आपको कुछ चाहिए? ज्ञान बरसाइए.
sir.
So Shashwat, how is family history different for the premature CAD? Coronary artery disease.
Sir, for
50.
Males and females, sir, for males 55 years first degree relative, and for females 65 years of first degree relative.
And is it the same in Indian context or no?
Indian 10 years earlier, sir, 45 and 55.
Correct.
Right. And also nocturnal, I mean, PND you would not get also because of the sympathetic, like you give beta blockers to alleviate the symptoms. Heart rate is a very important predictor, as Dr. Mohit has already mentioned, but so also the withdrawal of the sympathetic tone that would also lead to reduction in the LVOT obstruction being further, accentuated. Once you have that thing, that will also come down. All right. Go ahead.
Now we enter into the clinical examination. Shashwat, you have three differentials in your mind, right?
Yes, sir. Yes, sir.
Three differentials in your mind. Your whole examination now should be focused on ruling out and ruling in these differentials. Every step that you mentioned should either contribute, should be neutral, or should relegate or decrease the chances of that particular diagnosis. Go ahead with these, with good, positive, and powerful findings.
Sir, the patient is conscious, cooperative, oriented to
Positive,
science-based
powerful
person.
findings.
Okay, sir. The BMI of the patient is normal. There's no pallor, icterus, cyanosis, clubbing, or pedal edema. GVP is normal with normal waveforms. Pulse is 74 per minute.
Why did you ask
regular.
about lymphadenopathy in this case? What were you thinking?
Sir, as a part of general examination, I did, sir. Otherwise,
No,
there's
this
no
is wrong then. Then everything that you are examining should be contributing to this. Why do you think about cyanosis? Do you think a patient of a hypertrophic cardiomyopathy will develop cyanosis, will have this or not?
No, sir.
No. So then it is of no significance. Everything that you utter should come with a clinical consequence. Everything should be relevant. You are ruling out something or ruling in something, just completion's sake is no answer, isn't it? So that is why I'm telling you that everything should be linked to this particular case. JVP, you say you have a prominent A wave, which is more than a V wave. Do you think this matches with the hemodynamic session that I took?
JVP normal, A wave is more than V wave. Is it a normal thing in a normal individual or?
So in a normal individual, A wave is usually more than the V wave, sir.
Right.
Okay. So is it pathologically more or it is physiologically more?
So physiologically more, sir.
Physiologically more. So you think that JVP is unremarkable in this particular case, right? It is not contributing to it. What would you have
Yes,
a typical JVP in a case of a severe AS? And how would you have a JVP in a case of a severe hypertrophic obstructive cardiomyopathy? Such symptomatic. I just showed you the hemodynamic.
In cases of hypertrophic obstructive cardiomyopathy,
Yes.
sir, in
Describe the
patients of
JVP
HOCM,
in
sir,
HOCM.
in HOCM, sir, due to Bernheim effect, we could get a prominent A wave, sir. As the IVS verges towards the RV end diastolic pressure is changed. So the RA has to pump against a smaller cavity. So sometimes, sir, A waves can be prominent.
So basically, both have a typically A wave which is prominent. That is very, very important. Okay. So this is generally.
Yes.
Now go ahead.
Yes.
Pulse.
If you have RVOT obstruction, which is present in, as Dr. Mohit said, in HOCM in 20%,
Yes.
right? So that will add to further value. And
Yes.
also the cyanosis part, do you know any differentials of HOCM, the mimics of HOCM where you can have cyanosis? What are the infiltrative disorders where you can have associated shunts which can lead to cyanosis? Okay, go ahead.
The pulse is 74 per minute, regular rhythm, normal volume, bisvariance character, equal on both sides. There is no radioradial or radiofemoral delay. All peripheral pulses are well fed. The blood
Just a minute. One thing is, Dr.
pressure is
Kamal,
normal in
that
all
you
four limbs.
should all be
Respiration is
aware of the mimics of HCM. Very, very important. That is very important. In adulthood, you have Anderson-Fabry's disease, which is very less diagnosed here, glycogen storage and amyloidosis. You should all be aware of this. Go and read your guidelines for this. Now, this pulse contributes to a diagnosis or rules out something, anything clearly, yes or no?
Yes, sir, it contributes to my diagnosis, sir. It rules out valvular aortic stenosis.
It rules out a valvular aortic stenosis. You won't expect a bisvariance character in a pulse in a typical aortic stenosis. Agreed or not?
You should have mentioned a little bit about carotid pulse. That would have been probably a good idea.
Yeah. You should mention that which pulse. Very, very right. You know, it is very important that which pulse are you measuring. So,
yes, sir, bisvariance character in the carotid pulse.
What kind of pulse do you see in a case of aortic stenosis or obstruction at the valvular aortic level? It's a
Sir, there is a classical pulsus parvus et tardus.
Parvus et tardus. Slow rising
parvus
and
delayed
peaking.
Yes,
delayed peaking pulse. So
delayed peaking.
It is totally contrasting from bisvariance. If it is a bisvariance pulse, it can be in all probabilities contributing to the hypertrophic obstructive cardiomyopathy or other associated lesions. Patient might be having a aortic regurgitation, severe AS with severe AR, then it could be present, isn't it? AS with aortic regurgitation prominent, then this bisvariance factor may be present. Otherwise, it is not seen, isn't it? So bisvariance points towards a high possibility of a cardiomyopathy. Can you have a bisvariance characters in a coronary artery disease or not?
Sir, coronary artery disease with
when do we have a double peaking pulse in a coronary artery disease? What is it called?
Sir, severe LV dysfunction, sir.
Yeah.
And sir,
what is that pulse called?
Sir, dicrotic pulse, sir.
So, dicrotic pulse?
Dicrotic is found in something else.
Severe LV dysfunction. Okay, your answer is right, that you have a very severe LV dysfunction. You have a double peaking pulse, one in the systole and one in the diastole. So this pulse suggests that your possibility diagnosis of a hypertrophic cardiomyopathy is a strong diagnosis, right? Agreed? So the stenosis level, stenotic lesion at the valve goes down and this comes up. Go ahead to your blood pressure.
Yes, sir. Blood pressure is normal in all four limbs, sir.
Okay, go ahead.
So coming to systemic examination,
You mentioned no sign of infective Infective endocarditis, you mentioned one thing. So is there any possibility
sir.
of having infective endocarditis in hypertrophic cardiomyopathy, obstructive cardiomyopathy?
Yes, sir. There have been some very few cases of infective endocarditis, but it is very rare, sir.
It is, but it is not immune that you are trying to understand. Sure.
Yes.
Okay, chalo.
Sir, on systemic examination, cardiovascular system, on inspection, chest is bilaterally symmetrical without any deformity. Apex impulse is seen in the left fifth intercostal space outside the midclavicular line. There is no precordial pulsation seen, no scars. And sir, on palpation, trachea is central. Apex beat is in the left fifth intercostal space, 1 centimeter lateral to the midclavicular line. It is forceful and well sustained with triple apical impulse. There is no thrill, no palpable second heart sound, no parasternal lift or subsequent pulsations.
Now describe the apical impulse, on palpation a little more. The triple apical impulse means what exactly it is. Is it possible?
Yes, sir. I could appreciate, sir, 3 impulses, sir.
Right. So when you palpated the apex, what about the other hand? Where was it?
So over the carotid, sir.
Right. So if you try to compare this with carotid, what was the relationship between these? There are 3 impulses and carotid has got
Yes,
some.
sir. One impulse came just before the carotids, one was coinciding with the carotid, and one was just after the carotid.
So what is the reason for that? Which one is what? And explain those 3 impulses.
Sir, as the first impulse came before the carotid, most probably it is S4. The second, which came with the carotids, is a normal apical impulse, while the second after the carotid was most probably due to the mid-systolic obstruction at the LVOT level.
Right. But this is, you said is right, but a little bit of theoretical, because, when you really examine, sometimes the patient is having, if the patient has tachycardia, heart is faster, then the appreciation may not be that easy. One has to understand that. It is only possible once the heart rate is sort of, let us say, 60 to 70, then beyond 75, around 80, it may be difficult, not that easy. And also it depends on the patient build, how well is the carotid pulse fail. So many other fallacies are there, one has to understand. If you can describe that, then examiner will be happy that, yes, you are aware of the limitations of this correlation.
Yes, sir.
All answers need not be answered because you can always explain.
Yes, sir.
Please
So shall
go
I
ahead.
proceed? So on percussion, right heart border is substernal and left heart border corresponds with
No,
the
don't
apex.
mention percussion here. No, I think that
Okay,
many
sir.
examiner will not like it.
Okay, sir. So on auscultation, S1 is normal, S2 is narrow split with normal A2 and normal P2. S4 is heard at the apex. A harsh, high-pitched, grade 3/6 delayed peaking ejection systolic murmur is best heard in the left fourth intercostal space in the parasternal region. It is not conducted to the carotids or radiating to the back. Murmur increases on standing, valsalva, and decreases with supine position, squatting, and hand grip.
Right. I think there's one little question that we have. I think, Mohit, we can discuss about it. This maneuver in a clinical examination of hypertrophic obstructive cardiomyopathy, in our days we used to do, but I think of late examiners are not very keen of doing all the maneuvers. There may be some reason. What are your thoughts? Or when you examine the candidate as an examiner, what do you think? Do you expect all the maneuvers to be done, or you are happy with one, maybe few of them? Because maneuver has got a lot of, examiners.
So
they
that
don't
really
like.
depends on. See, in hypertrophic cardiomyopathy, remember that if you are doing an examination of 1,000 patients, 95 to 99% of the patients, you may come out very comfortably demonstrating and trying to make them do Valsalva and all other maneuvers. But if the patient is having a very obvious murmurs, I would be very happy not subjecting the patient to the maneuver, because one patient out of all, you may end up in a major disaster.
Right.
So that is why I would be very happy to understand. Like, I will ask you, my question to you, not to tell me 5 or 10 maneuvers. My question would be that what is your basic understanding about 3 classical pathophysiological features that are occurring in the hypertrophic cardiomyopathy? Either you are having a preload change, either you're having a contractility change, or either you're having an afterload change, right? This is how it is occurring. Now, to make you understand, try to understand, if you have a preload which will increase or decrease, that means LV volume ya to bada hai ya kam ho raha hai. If the preload is increasing, what will happen to the murmur of hypertrophic cardiomyopathy, Shashwat?
It will reduce, sir.
It will reduce logically. If you have a preload murmur which is increasing, you have a murmur that is reduced. Now, what about contractility? If you have a contractility, if it is more or either it is less, if you have a higher contractility, what will happen to the murmur? It will
increase, sir.
It will increase logically. This is how. So you should remember what are the murmurs that are going to increase the flow. Like preload is going to be increased by increase RV inflow. Like if you are squatting, if you are raising your leg, your blood flow is going to increase, isn't it? Preload is going to decrease by what? By Valsalva. If you do a Valsalva, preload or venous return will decrease. So what will happen? The murmur is going to increase. This is how you remember logically. What about the contractility? Contractility, all the maneuvers that are going to increase the contractility, again it will increase. If it is not going to increase, it is going to decrease. And what about the third one? The afterload. What is the pathophysiology of the afterload? When the afterload increases, what happens to the murmur?
So it reduces.
Huh?
As the afterload increases, the murmur reduces. As the afterload decreases, the murmur
as afterload increases, the murmur will reduce. Why? What is a typical murmur that increases the afterload? Typical maneuver? Hand grip. If you do a hand grip, it is going to decrease the murmur. Why the murmur is decreasing after the increase in afterload? Why, Shashwat?
So because as afterload increases, the LV cavity size increases. That's why, sir.
Yeah, LV cavity size increases. So now three things are happening. What are the maneuvers that are increasing the venous return? Leg raise and squatting. So murmur will decrease. What are the venous maneuvers that decrease the preload? Valsalva and standing. The murmur is going to increase. What are the maneuvers that are going to increase the afterload? Again, hand grip. That is going to increase. Amyl nitrate, that is going to decrease. Hence, the murmur will increase. Now, the question that is asked by the examiner, how will you do Valsalva? There are different ways. Either you can take a pump and you can inflate it to 40 millimeters of mercury. You know, that typical BP cup, that is one. Other one is you put a pressure on the abdomen. So there are 2 or 3 different ways you can go and read, and it all depends on the individual examiner. But I will evaluate my student on the understanding, not only on this capability just to tell me that there are 5 maneuvers, but how he's able to understand. Right. So this is what
we also, when you examine candidate, we don't really force them or ask them to do all the maneuvers in a patient's suspect hepatic cardiomyopathy.
Yes, but you should be aware that how this particular thing is done, how much time, 10 seconds, 15 seconds, 30 seconds, you should be aware of this. A very good suggested read for this is a clinical textbook of cardiology, you know, and that Dr. Kamal has written, and also one of that is CSI textbook. So you'll be able to have a deeper understanding of the dynamic maneuver. But remember, don't mug them up, have an understanding. Okay, go ahead.
Yeah, I think very beautifully pointed out. Dr. Rabin is trying to point out the same. And the other thing is the demonstration that you may actually be asked is to look at the change in the gradient when you're looking at the LVOT gradient on echocardiography in supine versus standing. That also actually, or leg raising for that matter, or something on that format rather than just trying to auscultate and show the demonstration in the dynamic maneuvers. So
after echo came in, all these things are not, we are not very keen. Because there are problems which may happen, especially with Valsalva. I have seen candidates being very aggressive Valsalva at creating problems. Then you get confused in an exam environment. Yeah, go ahead, Shashwat, go ahead.
Sir. So other system examinations were normal, sir. So on summarizing, 27 years old male patient with shortness of breath and typical angina chest pain since last 3 to 4 months. Family history of sudden cardiac death in elder brother. On examination, found to have Bispherian pulse with normal blood pressure and GVP. Cardiomegaly with a triple apical impulse. LV S4 and a grade 3 delayed peaking ejection systolic murmur in the 4th intercostal space, which increases on intensity with standing and decreases on lying down and squatting. So, sir, my final diagnosis would be primary myocardial disease with a hypertrophic obstructive cardiomyopathy, no pulmonary artery hypertension, without congestive heart failure, in sinus rhythm, currently in NYHA class 2.
Let us say this patient having hypertrophic cardiomyopathy in heart failure, now with so-called congestive heart failure, what are the clinical signs which will actually change? They will not be found. Because of there will be some change of hemodynamics. So which clinical signs will not be that important, not be that prominent, right, as it is found with preserved ejection fraction?
Yes, sir. The Bispherian pulse will subside, sir, and the murmur of HOCM will reduce. And sir, the patient will have more of orthopnea and PND, sir.
That is symptom, sign. JVP?
GVP will raise, sir. GVP will be raised.
Yeah, because even you have to need to understand for a hypertrophic cardiomyopathy to get a severe, let us say, pulmonary hypertension, right heart failure, tricuspid regurgitation is very, very rare, very late. And if that normally, so that kind of patients are not given an exam. That is almost like a terminal thing. Couple of things like atrial fibrillation, advanced heart failure. These are the almost like, these are ominous sign of hypertrophic obstructive cardiomyopathy. So, but there are certain signs which that may indicate that now this patient is going towards heart failure. For example, the pulse character of the pulse, the jugular venous pressure, the triple apical impulse, which we normally found in this case, because there may be a tachycardia, therefore that triple apical impulse may not be there. So there are some changes of hemodynamics which may happen in presence of a heart failure, especially in early heart failure. This is the early indicator that the patient is going into left ventricular systolic dysfunction.
Yes, sir.
Okay, and then what are you going to do?
So then we proceeded with doing the ECG of the patient, sir.
Right.
Here the ECG is taken in half standard, sir. It is a 12-lead surface ECG with normal sinus rhythm. The axis is around plus 60 degrees. PR interval is 160 milliseconds, and QRS duration is 80 milliseconds, not very prolonged, sir. Then, sir, as we can see in leads V3, V4, the R wave descending limb has some notching. Then, sir, there is a ST segment is not very much depressed, but there is deep and symmetrical T wave inversion is seen, sir. And the ST segment T wave angle is like a shelf-like angle, sir.
What about the
also, sir,
QRS duration? QRS duration.
Duration is 80 milliseconds, sir. Not much prolonged, sir. 80 to 100 milliseconds, sir.
So which QRS duration, which lead you are taking for QRS duration?
Sir, V1, sir.
You are taking V1. Why not AVF?
So whichever lead has the maximum. Duration, we have to take that, sir.
So take that. That is one thing.
Yes, sir.
Left ventricular hypertrophy there is anyway. And patient
Yes,
is in
sir.
sinus rhythm. You have to mention what is the heart
Sinus
rate?
rhythm.
What is the heart rate?
So 68 per minute, sir.
So heart rate is 1, 2, 3, 4, isn't it? So if
Yes,
this 4 is less than 60. No, 1, 2, 3, 4. No, it's a 4. Yeah, 68 acceptable. So that's fine.
Yes, sir.
So left ventricular hypertrophy and sinus rhythm. These are the things to be mentioned because sinus rhythm is a very important component. Any
Yes, sir.
left atrial enlargement?
No, sir. Left atrial enlargement is not there.
So that negative finding also has to be mentioned in the ECG because left atrial enlargement has got some relationship about the prognosis of the condition of the heart. So there is the left ventricular hypertrophy, there is a symmetrical T wave inversion, there is a T wave inversion you said, and no evidence and sinus rhythm and no left atrial enlargement.
Yes, sir.
These are the points to be mentioned.
Yes, sir.
And if you look at the lead V2, you see that what happened to that T wave. Why is this? There is an upright complex. What is that?
Sir, it is like a bifid T wave, sir.
Why? Why in V2? Why bifid? See, V3 doesn't have that.
Yes,
D1 up. And why in V2? V2 is location where T wave is depolarization. No?
Yes, sir.
So that is an observation you have to make a comment. So sometimes you can get this T wave because T wave is basically repolarization abnormality because it's very thick muscle. And V2, V3, that area indicates the septum, right? V2, V3.
Yes, sir.
So the septum is very much thick and hypertrophied. That is and in addition, if you really do a MRI of this group of patients, you find a lot of late gadolinium enhancement in that region. And so in addition to muscular hypertrophy, there can be associated fibrosis and what is called fibromuscular disarray. So therefore, the repolarization abnormality is reflected only in the septal lead in such fashion. So this is a very important observation. And there are sort of papers which correlated the electrocardiography finding, echocardiography finding, and cardiac MRI in hypertrophic cardiomyopathy and trying to correlate them and trying to understand these findings in relation to the cardiac MRI.
Yes, sir.
So how do these T inversion differ from, say, ICH, intracranial hemorrhages, or subarachnoid hemorrhage?
So
Or
those
for
T
that matter,
inversion would be
yeah.
broad-based,
And
sir, and symmetrical to asymmetrical, but mostly broad-based, sir.
deep and more deep.
Deep, yes, sir. Deep and broad-based.
Okay.
So Sir has beautifully told you how the predictors of sudden death in an ECG can be the repolarization abnormalities. So the QRS duration, IVCD, and T inversions are the predictor, and of course the QT interval are the predictors of sudden death in these group of patients.
Perfect. Excellent. Okay, you got echocardiography finding?
Yes, sir. So chest X-ray was normal in this patient.
Right.
Then, sir, coming to echocardiography, here we can see, sir, parasternal long axis view echo has been done, where there is a concentric variety of HCM could be seen, sir. Both IVS as well as the posterior wall is thickened, and it is homogeneously thickened, sir. And we can see there is a systolic anterior motion of the anteromitral leaflet.
Yeah, see,
Which I will
very
show
clearly
further.
seen in 2D, but it's maybe worthwhile to show a more
M1.
picture also.
Yes, sir. So in the other video, we can see, sir, a posterior directed jet of mitral regurgitation. It doesn't seem to be much severe, but there is some amount of MR, sir. And at the point of AMVL IVS contact, that we can see a mosaic pattern, sir, which also suggests some amount of obstruction at that level. So then there is parasternal short axis view at the level of mid cavity and aortic wall, just to show that aortic wall was normal in this patient and the LV cavity size was very much decreased.
Would you like to
This
make
is
some?
the,
Yes,
sir.
that is very nice, Sam. What type of Sam? Can you classify Sam?
Yes. Yes, sir. It has been classified into 4 grades. Grade 1 is when there is no AMVL septal contact, but the distance between AMVL and septum is more than 10 mm. Grade 2 is AMVL septum distance less than 10 mm. Grade 3 is there is a brief contact between AMVL and septum less than 30% of the systole, while grade 4 is AMVL septal contact more than 30% of the systole.
Yeah, and you in your M mode, you can see EF slope, and then there is one there is then the 2 positive waves. What are those 2 positive waves?
Sir, could be because of, sir, mitral valve anteromitral leaflet is long enough so that it is actually sucking into the LVOT, sir.
No, one is that this is a diastolic component, no? The EF.
Yes, sir.
The D, this is CD, then DE, EF, and there are 2 positive deflection. What are those waves called? Name of those waves. One is
A wave, sir.
other one?
Other one could be B bump, sir.
And what is the reason for that?
Sir, LV dysfunction, we get B bumps.
Not dysfunction. B bump is correlated with end-diastolic pressure, elevated ventricular end-diastolic. This is echocardic M mode. Good old days. Nowadays, probably people are not that much interested. In our time, that we had only M mode. We did not have in. When I did DM, just echo came in, no color, nothing, just echo. Even in GB Pant also, I still remember Dr. Khaliullah could manage to get one echo machine, and in our PGI we could manage to get one Diasonic, that company gone. So only black and white echo, and we are extremely excited about it. So that is the B hump correlated with LV, the elevated LVEDP, of course, LV diastolic dysfunction. Right. The other thing probably worth mentioning about the myocardium by the echo, you can see the myocardial texture can be assessed, not too accurately, but to some extent, it's not that the way the myocardium looks like in echocardiogram. It looks like it is a bit disorganized or a bit, a lot of granules, something, not exactly infiltrative type. So sometimes people used to describe them as fibromuscular disarray from the echocardiography point of view. Nowadays, those terms are changing, especially after cardiac MRI came in. Cardiac MRI has got a profound role in terms of diagnosis, prognosis, therapeutic intervention, a lot of things are there. The other thing in the septum part also you need to mention, because if you try to do an intervention, the interventional cardiologist would be interested to understand the septum in detail, because the area of the septum which need to be ablated by alcohol, that has to be sort of, that to be highlighted. This is just for your understanding. This may not be important to pass the exam, but this is for understanding. Okay, go ahead.
Yes, sir. Then, sir, this is the apical four-chamber view, sir. We can see both LV as well as RV is completely hypertrophic, sir. And down left picture, we can see, sir, in apical three-chamber view, the IVS and the posterior wall are almost touching each other.
Yes.
And there is a mosaic pattern just after that. So it is maybe suggestive of, sir, mid-cavitary obstruction, sir. Then, sir, continuous wave Doppler across the mid cavity was put, sir, which showed a typical dagger shaped pattern of the continuous wave Doppler, and the velocity was 5.16, whereas the peak gradient was 106.30 mm of Hg, which was significantly high. So, and then, sir, we measured the IVS and the posterior wall. The IVS was around 24 millimeters. Posterior wall was 20 millimeters, and the volume was also reduced, sir, around 26 mm.
Right. Okay.
Yes.
Next, could you do a MRI? No.
Sir, actually, MRI was planned this Monday, sir. Actually,
But this
MRI
is
is
one thing.
planned for this patient.
Nowadays, the examiners, even in your MRI, has become a very important investigation for hypertrophic cardiomyopathy.
Yes, sir.
So try to read and learn about it if possible. Some of your patient can have MRI, and that will help you to understand in a better way. Any other studies have been done? Any hemodynamics done? No.
So, as the patient has had typical anginal chest pain, we did a coronary angiogram, which came out to be normal, sir.
Right.
So
What
would
was
that be enough, or you are interested in coronary angiogram and defining some vessel?
some vessel? What about any particular branch which you are interested in?
So, septal branch of the left entry descending artery, sir.
So what was it in this particular case? And sort of
So,
describe septal branch of hypertrophic cardiomyopathy.
Yes, sir. Actually, the area supplied by the septal branch is more important, sir.
The septal branch goes down and it divides.
Yes, sir.
So that is a normal. There are a lot of variation of septal branch, by the way. Then which particular part of the heart is important from the ablation point of view, because if you can hit that, if you hit that, then you can have actually problem. Why? What is that?
So patient may land up in complete heart block, sir.
So
if it supplies the bundle branches.
So what we try to do, have you ever seen a septal ablation?
No, sir.
No, you have not seen. Right. Okay, doesn't matter. So there are a lot of sort of technique, like wearing, then balloon, then occlusion of the balloon, then flush it with saline to ensure that it doesn't backflow. Because if the backflow, then you had it. There's not even a 0.1 drop also will come back to the proximal part of the balloon. Then you had it. Very, very important. And then before that, you also try to do some kind of contrast echo to see that you are in the right place. Echo-guided septal alcohol septal ablation is very, very useful, because then you know that where you are heating, and then you have to monitor it before and after the ablation to see the pressure gradient.
What would you be looking out for in cardiac MR?
Sir, we would be looking out for certain things like, sir, LV mass index, the hypertrophy of the LV, the LV cavity size.
Now, what is that something extra information that the MR would give apart from what you already know from echo?
Sir, late gadolinium enhancement can
more than what is predictive of what?
15%. More than 15% is predictor of it is a risk marker for sudden cardiac death. Sir.
Right.
More than what percent you said?
15%, sir. 15.
Sure.
So there are two data. One is talking about 10%, other is talking about 15. 15 is the accepted value. 10% also increases risk, but 15 is something that you can consider for ICD as a minor criteria. But again, what are the important indications for putting an ICD in these patients?
Sir, if the patient has sustained VT or the patient has aborted episode
in
of
this
cardiac
patient,
arrest.
in this patient, no VT, in this patient.
Sir, in this patient, sir, family history of sudden cardiac death is a risk marker, sir.
One of the important markers, sir. Okay, one
Yes, sir.
of them. Do you sort of consider a kind of an ambulatory electrocardiography monitoring in view of the fact of family history of sudden cardiac death, or it may not contribute at all?
So it contributes, sir. History of
24
non-sustained
may or may
disease.
not, but a long-term sort of arrhythmia evaluation may be helpful.
Yes, sir.
That is, and there is any criteria of that this kind of arrhythmia load is significant.
Yes, sir. NSVT, sir. If more than 3 consecutive episodes of NSVT or one burst of more than 10 beats of a rate of more than 130 beats per minute is considered as a risk factor.
Can the long-term electrocardiogram monitoring as well as cardiac MRI, these are the two investigations which you should remember. They're very, very helpful for hypertrophic obstructive cardiomyopathy or obstructive hypertrophic cardiomyopathy in general. When you do call hypertrophic cardiomyopathy or hepatic obstructive cardiomyopathy, is relatively benign because it may not change the. Or do you think all hypertrophic cardiomyopathy will have the same natural history, or there are some variations? And if there is a variation, what are those factors which may not be that malignant as like others? Is there any criteria?
Yes, sir. Some forms of hypertrophic obstructive cardiomyopathy, like apical obstructive cardiomyopathy, concentric variety of obstructive cardiomyopathy, reverse variety of obstructive cardiomyopathy, they are very rare, sir, and they may or may not present in their lifetime, sir.
And the common ones with benign prognosis, which are they?
Sir, concentric variety.
Apicals are more common and they are more benign. Apical hypertrophic cardiomyopathy without obstruction. Which part are they most common in? Apical HCM?
Sir, apical and septal, sir.
No.
World.
Which geographically?
Epidemiologically. Where
Asians,
geographically?
Asians most commonly in Japanese, sir.
Japanese.
Far East. A lot of this apical cardiomyopathy.
So how would your LBBB or pre-existing RBBB determine what option of treatment you would offer to the patient? This patient had some amount of LBBB. What would you be cautious about and why?
Sir, if we go in for a septal reduction therapy in the form of myomectomy, sir, myomectomy is associated with more occurrence of LBBB. So I would be cautious while doing myomectomy. Myomectomy would be a contraindication.
Surgical myomectomy,
Surgical, sir. Surgical myomectomy would be a contraindication.
He already has a bundle branch, left bundle branch. If you will give an RBBB to him, then he will end up with a pacemaker, right? If he already has an LBBB, you'll go ahead with septal myomectomy, surgical myomectomy. You will go ahead with surgical myectomy. If he has an RBBB, you will go with alcohol septal ablation because alcohol septal ablation will create an RBBB. You don't do RBBB may create an LBBB and he'll end up with CHP, right? So if you have an LBBB, the preferred modality, though it's a minor criteria, we have separate criteria to define who gets what, but this is one of the electrophysiological way of judging. In a patient who's got a pre-existing LBBB, you don't do alcohol septal ablation. In a patient who's got a pre-existing RBBB, you don't do a surgical myectomy because then you create the other geopardy of the other and then you'll end up with a need for pacemaker.
Yes, sir.
And then
so what are the drugs that reduce the gradient?
Sir, beta blockers and calcium channel blockers, sir.
Do calcium channel blockers reduce the gradient?
Sir, actually, they increase the myocardial, reduce the diastolic.
So beta blockers to some extent can reduce because of blockade of sympathetic tone, but calcium channels don't. The drug to reduce gradient is disopyramide and mavacamten. So none of the negative heart rate. So how do beta blockers and calcium channel blockers work? By reduction in the heart rate. They don't primarily act to reduce the gradient by themselves. Negative inotropism is a mechanism of action of disopyramide. Is it available?
Yes, sir. So not easily available in India, sir.
And not easily, but it is available by the trade name of Norpace. But selective chemists would still keep it. It's available and it's not a very costly drug. So if you can search for it, you can, without mavacamten being available in our part of the world, it's a drug that you can chase in some of the patients. Some of the selective chemists would still get it ordered for you. So what is the side effect now when you want to use this drug? What are the potential side effects in a patient who's you starting on disopyramide?
So patient may have, sir, as it prolongs QTC, the patient may have arrhythmia, sir. Second, sir, it may have anticholinergic side effects. So we have to
That
be
is more
cautious
important.
in
That's
patients
more
with
common
prostatitism.
actually. Anticholinergics occur in almost 25 to 30% of the patient. So they can have visual disturbances, retention of urine. These patients, maybe if they are elderly, have prostatism, and then they can get precipitated. You would be cautious in using alpha blockers, as you know, for prostatism if they have. So those are the things that you should again keep in mind. Glaucoma worsening.
But any other thing? Any other sort of one is drug. Sort of what are your thoughts about pacemaker in not ICD, pacemaker in hypertrophic obstructive cardiomyopathy? At some point, people are extremely enthusiastic about dual chamber pacemaker. What is the current thought? Any idea?
Sir, actually, they are not indicated. I couldn't find any indication for dual chamber pacemakers, but previously, sir, historically, they were used. One of the thought process was that RV pacing would lead to the IVS movement more towards the RV. So the LVOT gradient would reduce.
And they're all rubbish. They found that they have no use. Then what are the indications of ICD? Just 1, 2, 3, 4. ICD in hypertrophic cardiomyopathy.
Sir, so one is for primary prevention, second is for secondary prevention. If a patient has had sudden cardiac arrest, which has been aborted or hemodynamically compromising VT, then the patient is class 1 indication for secondary prevention.
Right. What kind of ICD would you prefer? Single chamber, double chamber?
For primary prevention, we have to see the risk marker of sudden cardiac death, unexplained syndrome. Sir, double chamber, sir, dual chamber.
Dual chamber. Right. Any other thing would you like to consider in addition to drug, device, and anything else? What about family counseling and genetic testing?
Yes, sir. Family counseling.
Family
It is very important, sir.
Any correlation with
Yes,
the,
sir, genetic
of
counseling is
the
very
genes? Any particular gene been identified for hypertrophic obstructive cardiomyopathy? Gene study.
Yes, sir. There have been more than 1,500 genes, but most commonly identified genes are MYBPC3 gene and
Yeah, go ahead.
Sir, that's all, sir.
Yeah, I think Kamal, he's done a good job. I think he passed. Okay.
Yes, sir. He's done good. He's done well. So thank you, Dr. Shashwat. And thank you, Dr. Robin, for being with us and as a mentor for the session today. Also, I want to thank Dr. Mohit. And I could see Dr. Kishore Mishra. I think he is your PG teacher, Dr. Shashwat, is it? So he probably also is there online. So good to have you, Dr. Mishra. Thank you for joining. Dr. Mishra was our faculty last session. But I think because it was his resident, so he was keeping himself mute, like Dr. Robin was keeping mute for the previous session for quite some time. Dr. Mishra, you're muted.
Hello, good evening.
Mishra.
Yeah, actually, I was from the station, so, but I was following it up. I think our student has done a good job.
Yes, sir. Thank you very much for joining. Thank you. So thank you, everyone. Good night. We'll join for the next session next week. And over to Akhil and Dr. Charmi for the formalities.
Yeah, thank you so much, Dr. Kamal Sharma, sir. It's already been too late. So I would like to thank, it has been always been our endeavor at Macleods in providing latest scientific update for the cardiology postgraduate students under the India's eminent faculties and head of department. Like, I would like again thank you to Dr. Mahajan sir, Kamal Sharma sir, Robin Chakraborty sir, and Dr. Mohit Gupta sir, and Shashawat Sontake for excellent presentation. And thank you all for sharing your expertise to make our endeavor masterclass successful and fulfilling, sir. And even I would like to thank all the DM, DNB students who has attended across India, sir, for this live program. There are total more than 1100 registration done for today's program, sir. And more than 500 people have attended this live program, sir. So it's been without your expertise, your support is not possible, sir. Thank you so much for your valuable
The
time.
credit goes to Dr. Kamal and Dr. Mahajan.
I
Sir,
certainly
it's a
agree,
faculty like you that they come. Thank you very much, sir.
Thank you so much for all. And thank you, sir, from the Macleods team. And thank you, Dr. Chami, for you.
Thank you all.
Have a nice weekend.